Great. Hi, good afternoon, everyone, and thank you for joining us today. My name is Lori Smetanka, and I am the Executive Director of the National Consumer Voice for Quality Long-Term Care. We're glad you can join us this afternoon. We are doing the 6th in our webinar series of COVID-19 Advocating for Nursing Home Residents, which is being sponsored by the Consumer Voice, the Center for Medicare Advocacy, Justice and Aging, and the Long-Term Care Community Coalition. We have been holding these webinars for the last several weeks to bring you the latest information that we have on what's been happening with respect to the COVID crisis and long-term care facilities, sharing the latest guidance, actions at the state and federal levels, and other information that we are hearing about that we think you also would be interested in based on the questions that we have been getting. So next slide, please, Libby. So on our agenda today, we are going to be recapping where we are with nursing home issues related to COVID. Things have been changing so quickly over the last several weeks that we thought it would be helpful to review some of those changes, look at some of the issues that we've been talking about, and look at the impact on residents and also what's needed with respect to advocacy moving forward. We'll be hearing also more about infection control surveys being conducted around the country, and we'll be introducing a new resource from the Consumer Voice that includes some state-specific information in several areas. And then at the end, we will have time for discussion and questions. Some of you I've noticed already have been asking if we're going to continue doing these webinars. We've been doing them the last several weeks, and we're interested in hearing from you if you'd like us to continue. Do you find them useful? And what information, if we do continue, would you like us to share and cover? We know that we do expect a lot more things to be happening in the coming weeks, and definitely will be working to get that information to you, but we also want to make sure that we're meeting the needs that you all have with respect to these programs. So in the chats, you can let us know if you're finding them useful, what else you'd like to hear about if we do future programs, and we will be sharing more information early next week probably about plans for future programming. So I would like to, next slide please, share that the speakers today include Eric Carlson, Directing Attorney with Justice and Aging, Robin Grant, the Director of Public Policy and Advocacy at the Consumer Voice, Toby Edelman, Senior Policy Attorney with the Center for Medicare Advocacy, and Sam Brooks, Program Manager with the Consumer Voice. As a reminder, today's webinar is being recorded, and the recording and slides will be emailed out to you next week and also are posted on the Consumer Voice's website, along with the past recordings and slides from the previous webinars that we've been doing over the last several weeks. You can also get the link to today's slides in the chat box. You can download them, and we'll continue updating them throughout the webinar, or the link. We'll keep posting it throughout the webinar so that you can download it. All lines are muted throughout the webinar. Please post your questions for the presenters in the Q&A box on your control panel. Use the chat to make comments or to discuss points among yourselves. And as I mentioned at the end, we will get to as many questions as we can. So with that, I'm going to turn it over to Eric so that we can get started on the program today. Eric?
Terrific. Thanks, Lori. As Lori mentioned, this is a bit of an update, or not an update, but a review. If you've participated in these webinars every week, you've heard all of these things at some point over the last 6 weeks, but it's a helpful review, we think, to make sure that we understand where we are right now, particularly when there's some thought of so-called reopening of facilities or of our communities more broadly. So with that, we can go on to the next slide and talk about one of the topics that's certainly been the most prominent: visitation to nursing facilities. Ever since early March, as folks probably understand, visits have been extremely limited to nursing facilities. They've been limited pursuant to CMS guidance only to what are called compassionate care situations. And the example that CMS has given is an end-of-life situation. And what we understand from talking to folks is that oftentimes in facilities, that's being interpreted extremely narrowly, so as to not just include end-of-life situations, but oftentimes be limited to end-of-life situations, and in many cases only when people are absolutely positively in very, very difficult situations. So the suggestion, and Robin will talk more about advocacy, but on an individual level and on a policy level as well, it is worthwhile to point out to facilities and to state agencies that under CMS guidance, it's broader than that. It should be broader than that. And just out of fairness to residents and their families, there should be a little more leniency applied in understanding the importance of visitation, particularly as this emergency period extends from month to month. Then also, moving on to the next slide, there have been a sizable waiver of federal nursing facility regulations. This is just a subset of all the regulations that have been waived, those that seem particularly relevant. One is the 3-night hospitalization requirement as a prerequisite for Medicare coverage. Just to mention there, the waiver of this requirement does not eliminate the other requirements, most specifically the requirement that the resident require skilled nursing facility services or skilled rehabilitation services at a level that justifies Medicare reimbursement. But there's the requirement for the qualifying stay in a hospital has been eliminated in part to release what might otherwise be a tendency to hold folks in nursing facilities maybe a day or two beyond what would be preferable for hospital capacity issues. Some data submission requirements have been waived. The MDS assessment information, although it still has to be submitted, does not have to be submitted pursuant to the otherwise applicable deadlines. That staffing information from facilities based on their payroll is not being submitted, and there's some ambiguity about whether it'll ever be submitted. The advocacy point that all of us need to make with CMS is that it's absolutely imperative that that be submitted, and there's no reason, as things calm down a bit, why the facility can't submit that information, even though it may be submitted a week or two or a month or two beyond when it would otherwise have been due. What has been waived also is a resident's right to participate in groups. Obviously, under social distancing procedures, that activities in nursing facilities have not been eliminated, but have been changed significantly to recognize the need for social distancing. And in order to limit the opportunities for transmission of the virus within nursing facilities, there's also been waiver of some of the rights that otherwise allow residents to choose rooms and to choose roommates, and in some cases to object to changes that the facility wants to make. Moving on to the next slide, we'll just cover this briefly because it was covered in some significant detail last week. A new development is the requirement that nursing facilities be relatively transparent as to what's going on in their nursing facility in regards to COVID-19. Applicable now, it should be happening right now as we speak, is the lower bullet point. The facilities must inform residents and the representatives about confirmed cases and about 3 or more cases of individuals in the facility with respiratory symptoms. The facility has some discretion in doing that notification, posting or email or automated telephone calls. The guidance doesn't list some of the options, but doesn't mandate one particular type of communication, just mandates that it happen. And then in addition, on a broader level of transparency, facilities are required to communicate to the CDC, the federal CDC, at least weekly of suspected and confirmed cases, deaths, and some other demographic information. The submission of that information has already begun. CMS said informally last week that they intended to have that information online this week, the week that we're currently in. To my knowledge, that hasn't happened yet. But if CMS is reasonably consistent with their promises, we should expect that on a CMS website, probably Nursing Home Compare, within the next week. Then to talk about transfer and discharge, and moving on to the next slide, this also relates to a waiver of regulations. The transfer discharge regulations that ordinarily limit the reasons for transfer discharge, require advance notice, give appeal rights, have been waived in only these three situations. When a resident who's positive for COVID-19 is being transferred to a facility dedicated to care of COVID positive residents, a resident without COVID-19 is being transferred to a facility that's dedicated to residents that have not been infected, and transfer for a 14-day observation. Moving on to the next slide, the purpose of this is to encourage what the federal government and the states are terming cohorting, that is grouping people based on their status, their COVID positive or COVID negative status. And the benefit of that is relatively clear, that, or particularly the negative consequences of putting COVID positive residents with residents who are COVID negative. That being said, there's some real issues in treating people fairly and in making sure that the care is appropriate. As I mentioned, the CMS federal regulations have been waived, but just the waiver of regulations leaves a lot of details to be figured out. So much of this has to be determined by states. Robin will mention some advocacy here. I'll just mention now what's missing are standards for facilities, because if a facility is focusing on the care, specifically focusing on the care of COVID positive residents, you'd hope that there'd be absolute certainty, as close as we can get to certainty, that they're up to the task. And then secondly, even though there's a waiver of the regulations, that doesn't mean or shouldn't mean that people get some protection. Does waiver mean that they could just be moved at a whim with no advance notice and with no discussion? I think the advocacy point there is that the states have to figure out some middle ground. Maybe, of course, because the regulations are waived, they don't get the full-on 30-day notice with an opportunity to appeal that they would otherwise get, but they should get something, an opportunity to consult, some kind of collaborative process. And I think Robin may speak to that a bit. Moving on to surveys and enforcement, and the next slide, there's also been a significant change here. Ever since this emergency began in the front part of March, in-person surveys have been extremely limited, and surveys only been done for immediate jeopardy level violations, or incidents that have been triaged as potential immediate jeopardy, infection control surveys, and Toby will speak about those with much more detail, and then also initial certification surveys in order to get facilities up off the ground and operating to increase the capacity. So extremely limited level of surveying. And on top of that, there essentially hasn't been any enforcement, or very limited imposition of remedies, limited just to findings of immediate jeopardy. So over these last couple months, there's been an extreme narrowness of this surveying and enforcement that's been taking place across the country. And then, so starting from last week or so, we started talking about reopening. Moving on to the next slide. Just as states are talking about reopening, nursing facilities are talking about reopening, or at least at this point, CMS is talking about standards for reopening. CMS issued recommendations about a week and a half ago. I want to emphasize that it's even less mandatory than guidance. These are recommendations to the states, and the recommendations are set out based on 3 phases, the same way that the federal guidance for reopening the country, if that's the right phraseology, is organized. Under the CMS recommendations, phase 2 is essentially where we are right now. Everything extremely locked down. Entering phase 2 would require that the community level of COVID-19 be stable, and that there were no new nursing facility cases seen in for 14 days. And then moving on to phase 3 requires, again, stability in the community level of COVID-19 and no new onset nursing facility cases within the previous 28 days. I'll point out here that from the looking inside the facility, the movement from phase 1 to phase 2 really doesn't change that much. Maybe some slight increase in activities, or maybe allowing outings, some slight increase in the ability of so-called non-essential healthcare providers to enter, but relatively speaking, not that much. The big change would be moving from phase 2 to phase 3. Phase 3 would be much more like business as usual, full-on visitation, full-on surveying, but with the addition of the social distancing and the mask wearing and all the rest that we certainly weren't doing back in January and February of this year, but maybe part of our reality for some significant time into the future. Other reopening thoughts on the next slide. I want to mention the importance of testing, and that'll be discussed a couple times subsequently during today's webinar. Obviously, that's been a big issue in nursing facilities and in other settings. Under the CMS recommendations, there'd be testing of the staff as a baseline, and then weekly, and then also testing of residents to set a baseline, and then testing of residents if and when a case of a new infection were recorded in the facility. Also want to note this comment in the recommendations saying that a facility would start over if a new case were found, which obviously suggests some real difficulties. And indeed, moving on to the next slide, there are some real questions here. I don't think this is going to be easy for states, and maybe for any of us. And Robin may consider some of this. Specifically, this question, CMS at the beginning of these recommendations notes that there's decisions for state to make. Will these phases be set from state to state? So the entire state will be in phase 1 and then move to 2 and then to 3. Will this go region to region, county or some other lines drawn within the state, or facility by facility? And specifically, when you start talking about individual cases and starting over, it seems more like you're talking about the facility rather about the state or the county as a whole. So the states, it's going to have to be figured out. The CMS explicitly leaves that issue open in this reopening recommendation document. And then finally, moving on to the next slide, I'll just mention one other thing, and I think Sam will touch on this later as well. But just to note, and it's slightly separate to the side issue, there's efforts by nursing facility providers to seek immunity. There's efforts at the federal level that are just proposed at this point, and some state level moves, some of which have borne fruit, if that's the right term, from the provider's perspective. Roughly half the states have instituted some sort of immunity, sometimes through a governor's executive order and sometimes through state law. And just to be clear what I'm talking about, immunity here, we talk about freedom from legal consequences for what otherwise would be negligent action by a nursing facility. So to the extent that this would be applied to civil liability, a nursing facility under some level of immunity, and there's definite variation from what's been done in all the states, but would not be responsible for negligence, for example, and wouldn't be subject to suit in situations when the facility might otherwise be liable. Depending on the state, the lines are drawn in different ways. The state, for example, might excuse a facility from responsibility for its own negligent conduct, but nonetheless leave the facility responsible for intentional conduct. But again, it's difficult to generalize since this is all being done thus far at the state level. So with that, let me pause and pass the control over to Robin to talk about some advocacy issues.
Thank you, Eric. So in addition to reviewing the significant COVID-related policies and developments and issues that Eric just did so nicely, we felt it was also important to recap just a few of the advocacy recommendations that we've made over the course of this webinar series. So that's what I'm going to be talking about in the next few minutes. But before I start, I just want to stress that these are just a few of the recommendations, and for all the details, I would just refer you back to the recordings and the slides of previous webinars, as well as to our document that we discussed on one of the webinars that has recommendations for protecting residents and staff for state advocates, and that we issued at the end of April. So here are just a few key advocacy steps that we would encourage those of you who are advocating at the state level to pursue. So first, this one keeps coming up, but we still need adequate PPE and testing, including testing kits and supplies to do the testing. So I don't think I need to say much about this since basically we've been talking about these issues from day one. The only point I just want to mention is that yet another reason that adequate PPE and testing are so critical is because they are factors that CMS identified in terms of what needs to be considered in the reopening process. So facilities should not be moving forward if they don't have, for example, adequate PPE. So the second recommendation is tied to something that Eric mentioned, and that's to advocate for the establishment of criteria for COVID-only facilities. We are increasingly concerned that there are not criteria that a facility would have to meet in order to be designated as COVID only. So certainly there are no federal criteria at all. I think there are a few states that have some criteria, but the complete absence is extremely troubling because we're hearing about facilities with extremely poor records of care that are being permitted to serve as COVID-only facilities. And we're truly worried about the safety and well-being of residents in those facilities because obviously a resident with COVID has complex care needs and needs the best of care and certainly not the worst of care. So we strongly urge you to advocate for establishment of criteria. And if you refer back to our previous recommendations, we do have a set of criteria that we would recommend. So I definitely refer you back to that. So the next recommendation is again tied to a point that Eric covered, which is to protect residents during admission, transfer, and discharge. So there are many components to this issue, but two of the key elements, again, reflect what Eric said, which is to specifically advocate for residents to be given this advance notice, which had been waived. And we're suggesting that residents should be given at least 72 hours in advance of any COVID-related transfers. And we're also urging that you advocate for some kind of consultation to occur before a decision is made to transfer. So having facility staff with the ombudsman, maybe even state surveyors, having an advanced conversation with the resident and his or her representative to talk about options and make plans. I mean, are there alternatives? So to do that before any move is made to transfer a resident. I would just throw in there that a point we've been advocating for and suggesting that folks at the state level advocate for as well is for all other involuntary transfers or discharges to be prohibited during this time period. These evictions during this pandemic are really placing residents as well as the community that they're discharged into at risk of getting the virus or spreading the virus. Another recommendation is to advocate for daily reporting from the facility and daily monitoring from the state level of certain key data elements. I've listed just a few of those here, and those are things like the number of COVID cases, number of fatalities, staffing level, and so on. We just believe that this daily reporting is so important because we know the virus can spread so quickly, and that the number of cases and deaths can rapidly change. So it's really important that facilities report that on a daily basis. And it's equally important that that be monitored at the state level on a daily basis. Tracking this information is really critical so adjustments can be made to plans for reopening, for example, and for allocation of resources and for maybe identifying where the hot spots are and providing help. So the last three recommendations are related to reopening and are some of the recommendations I mentioned just last week, although it seems a lot longer ago. So first, because as Eric pointed out, so much of what's going to happen with reopening is going to be decided at the state level. So it's really important that state leaders hear the perspective of advocates when they're considering how nursing homes should be reopened and when. So we really urge you to advocate for the involvement of the long-term care ombudsman program and citizen advocacy groups in the decision-making process. So advocate for those representatives of those programs and groups to be at the table. Second, we think that relaxing the restrictions on visitation should be done in a phased-in approach, and that facilities should not wait until phase 3 and then suddenly throw their doors wide open. So we're suggesting that you advocate for a group of state stakeholders to come together, and we would recommend that that stakeholder group include residents and families, as well as certainly representatives from long-term care ombudsman program and citizen advocacy groups. But that group should come together to develop a plan, to think through some of these complicated issues, think through a plan for how visitation will slowly be opened over time. And we're also recommending that you advocate that this approach start with expanding how compassionate care situations are defined and interpreted. And Eric talked a little bit about that. We are seeing this be defined so narrowly that in essence it's almost you know, not applicable. So that seems like a very a good starting place as we open up visitation. And then last, according to CMS recommendations in its reopening document, state survey agencies are permitted to perform surveys that are based on their own state priorities. So right now we are across the country, everyone's very concerned about what's happening in nursing homes right now because there are basically no outside eyes and there's very little to no oversight. So it's critically important that surveyors get in facilities as soon as possible. So we're urging you to advocate with your state survey agency to set its priorities in such a way really that gives surveyors access and gets them into facilities immediately. I don't think we can wait any longer. So those are just a few of the recommendations that we have covered over the past few weeks. But I just want to end this part by saying we all know, and all of us participating in this webinar, listening, whatever, believe that residents matter. And that's why resident stories need to be told, and why our local, state, and national legislators and our government officials and our political leaders need to hear those stories. So I want to invite each and every one of you to help make that happen. So first, if you're a resident, a family member, an ombudsman, a citizen advocate, or anyone else who has any kind of experience, observation, information to share, go to our website. We have a new place now for telling your story. So your stories will help us in advocating for better policies for residents. If we get lots of stories, then we can really use them to make the case for to help save resident lives. So please tell your story. And then second, it's just critical that all of us contact our legislators and our key policymakers and share that story with them. You know, they need to know that residents matter and that action is absolutely needed to save residents' lives. So I can never stress enough that nothing is more powerful than legislators hearing directly from their constituents. That is just incredibly compelling. So just in closing, we've learned that the more of us that speak up, the louder our voice and the stronger our advocacy. So your voice has never been needed more than now. So get out there and tell your story. Thank you.
Thank you, Robin. That was pretty powerful, and I could not agree more about the importance of people telling their stories. I wanted to spend a few minutes this afternoon talking about the infection control surveys that we have finally begun to start hearing about. Next slide, please. We know that since March 20th, CMS has said that there should be a complete waiver of standard surveys. The only surveys that would be conducted would be complaint and facility reported incidents that the state triaged as immediate jeopardy and infection control surveys. Next slide, please. Early on, seems like early on, maybe a month and a half ago or so, CMS sent a number of surveys to Tony Chicotel, our colleague at California Advocates for Nursing Home Reform, in 2 batches. And he sent them to the rest of us. And I read these 171 surveys. They took place from late March to late April, and I wrote a report about them. I spoke about these a couple of webinars ago, but just to summarize the key findings. Next slide, please. There were 171. Two of them had occurred actually in early March, but I included them anyway. 3/4 did not cite any infection control deficiency. Now that's of course pretty surprising because infection control is the #1 deficiency cited in nursing homes. As Jordan Rao at Kaiser Health News has said, 2 out of 3 facilities are cited with infection control. It's the #1 deficiency. The #1 problem is hand washing. And yet these facilities, even though it was facilities that had a history of infection control problems and were in communities with community spread, so they'd be likely targets for problems in infection control. Nevertheless, more than 3/4 of them did not have an infection control deficiency. 41 of the 171 surveys did cite an infection control deficiency, but then almost 3/4 of them were cited as no harm at all. Only 3 cited immediate jeopardy, and one of them was the Life Care Center of Kirkland, where 3 months ago we first heard about COVID-19. Next slide, please. What we talked about last week was the new GAO report that came out May 20th, whose title tells it all. Infection control deficiencies were widespread and persistent in nursing homes prior to COVID-19 pandemic. Next slide, please. So the highlights of that report: 82% of nursing facilities were cited with 1 or more infection control deficiencies in the years 2013 to 2017, and 48% of the facilities had infection control deficiencies in multiple consecutive years. Clearly a serious problem in nursing homes. Next slide. What the GAO found was that 99% had been cited as no harm, 2/3 of them because no penalty was imposed or implemented, and 31% did have a penalty imposed, but it had corrected the non-compliance before the effective date of the penalty, and as a result, there was no penalty. So 1% of facilities with infection control deficiencies had any kind of financial penalty. 1%, that is the end. Next slide, please. Now, what CMS said a couple of weeks ago that came as a complete surprise to us is that 68 infection control surveys have been conducted. We thought the 171 that CMS sent to Tony was the complete universe of infection control deficiencies. But no, turns out there were 6,800. CMS says it's going to post these survey results on Nursing Home Compare, but that hasn't happened yet. And we've seen no analysis, no discussion of what these surveys found. But the media are beginning to read and describe the surveys at the state level. And I want to talk about 2 now. This is what alarmed me last night and compelled me to ask Lori if I could have a few minutes today to talk about these 2 state reports or 2 state articles. Next slide, please. We've heard, of course, that some states are citing infection control deficiencies as immediate jeopardy. We know some other states are actually saying, well, they're just informational surveys. We're not citing anything at all. We're just trying to see what's going on. But now we know that some states have done infection control surveys. So next slide, please. The 2 places I want to talk about, the 2 articles, are New York City and Kentucky. Both reported this week that there were very few or no infection control deficiencies cited in these surveys, even in facilities where many residents and many staff have died of COVID-19. And I was concerned about questionable survey practices that were identified pretty much in passing in the articles. First, that some of the surveys seemed to be remote surveys, not on-site at all. And secondly, that the state nursing home associations were praising and thanking the state for the collaborative approach in the survey process. Next slide, please. In New York City, was reported Wednesday that 25 nursing facilities where more than 600 residents died of COVID had no infection control deficiency cited, even though they had an infection control survey. That is sort of a shocking statistic. 25 facilities, more than 600 residents died, no infection control problem. One of the facilities, in fact, was surveyed 2 times after the families complained about the spread of COVID. But in neither survey did the survey agency find an infection control deficiency. 54 residents at that facility have died. Next slide, please. What the article also said, and this is the only sentence about this point, in some cases outside New York City, inspections have been conducted entirely or partially by video chat. Now, I don't really know what that means, and I'd like to find out more about that, but it certainly sounds like they're not being conducted on site, and surveys are supposed to be conducted on site. Several webinars ago, we heard from the Connecticut Ombudsman describing a monitoring program where the state survey agency was monitoring remotely nursing homes on a daily basis where there was COVID-19. That seems to me to be quite different from an inspection. And if inspections are being conducted by video chat, that's giving the facility an opportunity to select which residents, which parts of facilities, what the surveyor sees. And that seems to me to be very alarming. Next slide, please. This is the article where I got this information. So it's Susan Jaffe's article in the City from May 27th. Next slide, please. In Kentucky, the reporter looked at 154 infection control surveys that had been conducted. And these surveys included facilities that had reported some of the highest number of cases of COVID-19. But only 2 of these 154 nursing homes had an infection control deficiency cited, 2 of 154. Now in 2019, 102 nursing facilities were cited with infection control deficiencies in Kentucky, 102 facilities out of 285. But now suddenly only 2 out of 154 facilities had an infection control survey, deficiency cited from the survey. Next slide, please. The president of the Association of Healthcare Facilities told the reporter that the facilities were pleased with the collaborative, and that was her word, collaborative process of the COVID inspections, and she hopes facilities can continue to work more closely with state and federal regulators once the virus has passed. That's always very alarming to advocates to hear the word about collaboration. Regulatory agencies are not collaborators with nursing homes, they're the regulatory agencies there to set the standards and to determine compliance with those standards. So I'd like to know a little bit more about this collaborative process, but it does make me nervous. Next slide, please. And here's the article. It's Bailey Loosemore's column, article in the Louisville Courier Journal last night. Most Kentucky nursing homes have passed COVID-19 inspections despite widespread outbreaks. Next slide, please. So I'm very concerned about this issue, clearly. What is going on in these infection control surveys? Are they actually real surveys? Are surveyors on site? What are they looking at? How long are they staying? What are they identifying? And if they're identifying nothing, how can that be? So please monitor to the extent that you can and find out what the surveys are saying in your community, and please let us know what you find out. We'd like to keep going on this. Next slide is just where I am, who I am, and where I am. And I'm happy to talk to anybody. And now I'd like to pass this on to Sam. Thank you.
Thank you, Toby. I wanted to, I'm going to direct, our next presentation is going to be actually directed to our website. And we wanted to announce some some new news, information that's going to be on our website. Just let me get my screen up here. 1 second, please. I'm sorry about this. I don't know what the problem is. There we go. So this is the Consumer Voices website, and we're very excited to announce that we're adding some new information today. And just from the questions that we have received, I can tell that a lot of you will be interested in it. So this is our main page, the consumervoice.org, but we've been maintaining a COVID-19 page throughout the pandemic and the crisis. And this page has a lot of useful advocacy tools and informational tools for individuals to use when dealing with COVID-19 in facilities. However, today, what we're going to talk about is this new information that we are going to be sharing, which is right here at the top of the page. And what we have created is an interactive map for people that come to the website. And what we're tracking now is various state policies as regards to nursing homes and their response to the COVID-19 crisis. So specifically, what we're tracking is testing, the state's policy on testing, the state's policy on releasing information to the public, and also the state's granting of immunity or the potential of granting nursing facilities and assisted facility living facilities immunity from civil liability and from criminal liability. So just to illustrate, you can find your state here on the map and click on it. And what you'll be done is you'll be brought to the state's page. And as I said before, what we're primarily focused on right now, we may add categories later, but as of right now, we're worried about or publishing information about reporting, testing, and immunity. So as you will see, that the first set of data or information we're sharing is the state's policy on releasing information about COVID in nursing home facilities. And how we're tracking this, or how we're breaking this out, is what the state is letting the public know. It's not what the state is requiring facilities to report to them, but what the state is letting the public know about COVID. And specifically, we're looking at if they are reporting resident cases, resident deaths, reporting staff cases, and also is that information broken down by facility. Some states have taken position that they will release information on total number of cases, but they're not giving information on specific facilities. In this instance, New Jersey is releasing pretty much all the information on assisted living facilities and nursing homes on their public website. And here there's a link to where the source is, and that should bring you to what the source of our information is from. Should be noted that the Centers for Medicare and Medicaid Services have required facilities to report certain information to the CDC, and the CDC will then share that information with CMS, and CMS is going to post that information on its data sharing website. What we're tracking here is separate from that requirement. What states are doing separate from that. However, you can go here, actually, CMS, when it does release the information, has said that they will release the information here on its data website, but it is not there yet. And additionally, we've also created something to show you what those reporting requirements are in the CMS rule. So that should be there for you as well. Our next category here is testing, and I saw a lot of questions in testing. And as we talked about before in some of these webinars, there's no uniform policy. The federal government is not requiring any state to require testing. So it's coming down to each state adopting its own policy. Those policies vary from testing all residents to testing only when there's an outbreak, or it's not requiring any testing. They're very sort of particular instances, but we try to capture them the best we can. So what we're looking at here is the state requiring all residents to be tested? And again, some states aren't, and they're only requiring after an outbreak, and then some states are doing some testing, but it's just really no clear policy. In New Jersey, they've adopted one of the most rigorous testing policies, or have announced the most rigorous testing policies, and they're testing every 3 to 7 days. And we are showing when this was ordered and whether the staff is required to be tested as well. And we try, as best we could, we tried to determine who was conducting the testing. Is the state mandating that facilities do it? And there was a question, I think from someone in Illinois, that said that the state is requiring it, but the facilities say they can't do it without help from the state. So that's problematic as well. And also the questions are about whether they're requiring assisted living facility residents to be tested. And lastly here, and Eric touched upon this, there's a trend nationwide for states, either through executive orders by the governor or now, which is trending much more, are laws providing immunity to nursing homes for any harm or even death that nursing facilities, or in some instances assisted living facilities, their substandard care caused during the COVID-19 pandemic. And the majority of states who are offering immunity are just offering civil immunity. However, in this instance, New Jersey and also New York are offering criminal immunity. So what we're trying to show and capture here is that, are they offering civil or criminal immunity? How was it created? Through executive order by the governor, or was a law passed? When was it enacted? Most executive orders in the law are being applied retroactively. So the date enacted doesn't necessarily announce when immunity starts. They're all really retroactive. Expiration date. Some are open-ended. The laws are open-ended. Some say when the emergency ends, and some put specific dates on them. And in states where immunity hasn't been granted or has been granted only through an executive order, we tried to track if there was pending legislation. Obviously, in New Jersey, there's already been legislation, so it's not pending. But on a state where there is pending legislation, we will also link to where that legislation is. One caveat on this is that things are changing sometimes daily with all this information. For instance, someone in the comments said that Illinois just issued an order requiring all residents to be tested. So what we will be doing, we will be updating this information, but it's very important that when you come to the website that you look at as of the current as of date, because as many people know, things on the ground with COVID-19 are changing daily. However, we're going to try to keep this as up to date as possible, so it's a useful resource for advocates and family members and residents. So I'm happy, we're going to take some questions next, but hopefully you will go to the website and take advantage of this, and it will be a useful tool for all of you. Thank you.
Thanks so much, Sam and Eric, Robin, and Toby for your terrific and informative presentations today. We always appreciate the expertise that you bring to these issues, and so appreciate your spending the time on these issues. So we have just a few minutes left to take a few questions today. There are a number that have come in, and I know as Sam's going to help with questions, but as he's and Jocelyn's going to help with some questions as well. But as they're getting situated, I'll just pick one that has come out. There's a comment that came in: how can meaningful surveys be done remotely? I think exactly is the point. I think you need to have eyes on and to be looking at what's going on in the facilities in order to do them remotely. There were a couple of questions about how to get the infection control surveys. Toby, do you have a thought about that?
I think CMS has told us that it's going to post these surveys. They're not going to count them in the health inspection. That rating has been frozen, but I think they're supposed to be made available. I don't know, maybe the reporters are doing Freedom of Information Act requests. that seems to be the way that they're finding out about these surveys. So I'm not sure if that's what, what the rest of us could do as well. Could ask the reporters how they got them, because it is an interesting question. But they're certainly delving into this. It's the kind of thing that local reporters want to find out about.
Mm-hmm. And they could maybe even ask their departments of health as well. Sure. Maybe that's a
sure.
possibility.
Because the survey, any kind of survey information is supposed to be made public. I think it's 14 days after the facility gets it. So, it should be publicly available. Right. But I think they're getting them in batches. That's not just which particular, if a facility had a survey, you could ask for it, but how do you get a whole 174 surveys as the reporter did in Kentucky?
Right. Okay.
Yeah.
Sam or Jocelyn, do you have a question queued up?
Sure. Somebody asked a question actually about employees and what employees of nursing homes can do who are concerned about the nursing home exercising unsafe practices. They mentioned, the situation of nursing homes telling staff that has been tested, people who are maybe suspected of having COVID, telling them that they have to work while they're waiting for results to come back, having staff members work when they have symptoms, and situations like that. Just sort of advocacy for employees of nursing facilities.
Mm-hmm. Does anyone want to take a stab at that? Well, I can start.
This is Toby. No, go ahead, Lori. Go ahead.
Sorry, sorry. I was talking on mute.
Okay.
Sorry.
Well, then go ahead, Robin.
Oh my God. So one possible place to turn is OSHA. Now I'm hearing not so good things about where OSHA is in terms of guidelines and enforcing things, but that is a place for concerns about the workplace. There are also some really good organizations like National Employment, I think National Health Law, I think it is. I'm sorry, I'm getting my acronyms mixed up here, but that really do a great job of keeping up on the laws that relate particularly to workers. Toby, do you know the name? National Employment?
Well, there's the National Health Law Program, National, I think, Employment Law Center, or
yes, something like that. Might be places to turn for information about what protections are out there. So just a couple of thoughts.
Mm-hmm. Workers could call in a complaint to the health department and talk about immediate jeopardy, that, make an anonymous complaint that they are being asked to work when they are symptomatic and it's not safe, or they're not given PPE. It's possible the state would take that seriously. Maybe they can make an anonymous report to a newspaper, a local newspaper. It was the anonymous report to the police about a body in a shed at the Andover facility in New Jersey that got the police out there and finding 17 bodies in a makeshift morgue. And then the survey agency went in. When it gets into the newspaper, I think the survey agencies follow and they will do a survey. Mm-hmm. So, I think if people could try to do it anonymously, I understand the fear of retaliation, but I think the press is looking for information.
Yeah, thank you. Those are the things I was going to mention as well. So we may be able to have time for one more question today. So Sam or Jocelyn, do you have one queued up?
Sure. There was a question about testing, and someone noted that some of these tests, the long swab tests, can be very unpleasant. They said they're concerned about frail residents having these tests, and so we're asking whether or not residents can refuse testing. But the second part of the question noted that the situation is that when some residents leave facilities and come back, in addition to being quarantined, they're being told they need to take multiple tests. Someone noted on day 2, on day 4, a total of about 4 tests. And if they refuse, they risk being asked to leave the facility. So I guess the question is, what rights do residents have in those situations?
Okay. Anyone want to take a stab?
Yeah, I'll start. In general, I think the legal analysis says you have a right to
Eric, could you move a little closer to your microphone? You're very far
Sorry
away.
about that. Okay. I'll snap back into speaking mode here. That people have a right to refuse, or you have to consent to undergo a medical procedure. And I think that same thing is true here. So I think you do have the right to refuse a test. I don't know of anything that's changed that legally in this situation. And then secondly, I don't think, the facility doesn't have the right to, I mean, I guess if they tried to get you to force you to leave, they would say that you're a danger to the safety of others, and they would potentially have a claim. That's more the legal analysis. My own editorializing here. Under the circumstances, I recognize the value of tests. In these situations, there may be a point where it's excessive or unfair, particularly when someone's forced to do it under a threat of being otherwise forced out. But there's also the clear benefit and the danger if infected folks get in contact with others, which is just a way of saying there's the law here, there's some practical realities floating in, and I think that answer, the question makes it difficult to give a 3-sentence answer that just sums it up or wraps it up and tells people what to do.
Mm-hmm. And certainly, thanks, Eric. Certainly, if you have concerns, I would suggest also you contact your ombudsman program for assistance and advocacy. In these situations, you can find your long-term care ombudsman on the Consumer Voices website. We have another map there, Get Help, where you can find your both state and local ombudsman contact information. So with that, I think we're going to have to close for today. We're trying to keep these programs to about an hour to be respectful of everyone's time. I'm seeing a lot of support for continuing to do the webinars, and we will try to be doing that as best we can. We'll send more information out very early next week about that. Let us know the types of other issues that you'd also like to be hearing about. We are, as I mentioned, trying to keep on track of everything that's happening and share that with you as we get the information. We're trying to pass it on to you as best we can each week. And the other thing is, I know we don't get to all of the questions that come in. We are reading them. We are trying to address them in future programming as best we can on some of the issues. We can't always answer very specific ones, but we're trying to get you the best information we can about them. And we have updated on the Consumer Voice website the frequently asked questions page, so you can look there as well for some additional answers to questions that have been posed over the past several weeks on these webinars. So thank you so much for your participation today. Enjoy your weekend, and we will talk to you again soon, and we'll close out for today. Thank you. Bye-bye.